everyone. Welcome back after a good lunch.
Now I will invite Dr. Usha ji for pros and cons of the robotic surgery for myomectomy.
Dr. Usha M Kumar, she is Associated Director, Max Super Speciality Hospital, and she has done more than 10,000 surgeries. Over to you, ma'am. Thank you.
Thank you very much for the kind introduction. So the topic of my talk, first of all, I would like to congratulate and convey my gratitude to the whole organizing team for organizing such a wonderful conference and inviting me over here. So the topic of my talk is robotic myomectomy. Nowadays, I am sure everybody knows the era of robotics, and we people, I have been doing surgery from last 30 years. So now shifted from last 5 years, shifted from laparoscopy to robotic surgeries. So what is, if we talk about the pros and cons about robotic surgery, all of us we know, actually the robo has been designed by Stanford Institute of US, and then they designed it to treat the wounded soldiers as telesurgery, to treat the wounded soldier in the battlefield. But the technique, the evolution has happened so much nowadays. Nowadays we are sitting in the same room and we are treating the patient in the same room. So if the slide is not good, yeah. So what we do, if we talk about the myomectomy, MRI is the GPS guide for doing robotic myomectomy or any myomectomy. We should know what are the number, site and size, exact number of the fibroid. Of course, beside the fibroids, we should rule out the possibility of adenomyosis and sarcoma. That is very, very important. And robo gives you the freedom. You can put these MRI films in the view box and sit down on the console, and you can view these pictures. You can come, and anytime when you do myomectomy, you are feeling lost, the last fibroid should not be left behind. You can come to the view box and you can see the pictures. Here you can see how happily I am sitting on the console. So robo doesn't do the surgery. Actually, we are doing surgery and we are using the robo arm, and I call it, this console is a very happy console. This is something dream come true for the surgeon. You sit happily over here because this is not a simple console. This is ergonomically designed console where you can see the high definition and high definition 3D vision, and you control these mounted laparoscopic instrument which are mounted on the robo arm, and you control it with the master control and the foot pedals, and the precision is so much you can dissect very delicate tissue in highly precise manner. So this MRI film I was telling you about, just to know the size, site and the number of the fibroid. And if you can see this picture, this girl, 25 years old girl I had operated, she had multiple fibroid. If you see this picture, you feel very happy because here you can see this, the fibroid was touching the GP sternum, but it has got a broad pedicle. And robo makes this surgery very easy because I'll show you how is the port placement, and then you will understand. So these are the port placement of robo, and the thing is, these port size is all of 8 millimeter. So you can put your camera in any one of these port, and you can come down, come below and beyond to the fibroid. You can manipulate the uterus, you can manipulate the fibroid with the help of these instruments. So what could be the challenges? It's like the patients with are obese, BMI is very high with previous multiple surgeries, and they had deadly combination of endometriosis, fibroid and previous multiple surgeries. So when they sit in the OPD and you do commitment to do surgery, it's like, I always remember the Salman Khan's dialogue that when I do commitment, ek baar commitment kar diya to main khud ki bhi nahi sunta. So robo helps you to execute such surgery very nicely because obesity you need not to bother. You are not standing and you are not physically in touch with the patient. You are sitting on the console, and you can, once the robo get docked in, you are very comfortable to do surgeries. So previous multiple surgery, this is one of the captive uterus. Again, you have got very precise vision. You have got the monopolar, bipolar in your hand, and then beautifully you can dissect the uterus. This video, I am going to show you a few videos about it. And this is the, now if we talk about the challenges like multiple fibroids, sometimes the broad ligament fibroid, sometimes the cervical fibroid, which are very difficult to treat. And all gynecologists and laparoscopy surgeon, we know what is the biggest fear. Biggest fear is to damage the uterine artery, damage the ureter. So this is, yeah, thank you so much. So firefly technique you can use, and this I am dissecting the grade 4 endometriosis. What we do in the firefly technique, you just have to put 5 ml of indocyanine dye diluted in 10 ml of saline, and before doing the surgery you do cystoscopy and put indocyanine dye, 5 ml of indocyanine dye in each ureter, and this remain into the system for another 3-4 hours. And in between the surgery you can see the ureter very nicely like this. So this is endometriosis surgery. I am dissecting the ureters, but when you are doing myomectomy, there is no need to dissect the ureter, but continuously during the surgery you can watch your ureter, you can prevent the ureteric injury if you are dealing with the cervical fibroid and broad ligament fibroids. Uterine artery ligation is no more my cup of tea, because uterine artery ligation you have to dissect so much in the retroperitoneal space, and just to inject 20, either you inject vasopressin, diluted vasopressin, and 10 units in 400 ml, or you can just, nowadays what I do, I run 20 units of syntocinon diluted in 500 ml of the saline at the rate of 80 ml per hour, and it gives tremendous reduction in blood loss. So this is one, and I'll show you the video of the patient who had multiple uterine fibroid, how Robo is making so easy. So here you can see, this is, fantastic surgery. There is nothing like big fibroid, multiple fibroid, nothing like difficult fibroid. What matters? What strategies you are putting into. So what I do, I go below. You are not camera dependent. You are not assistant dependent. You take your camera, zoom in, go below and beyond the fibroid to the fibroid. Once you dissect out the biggest fibroid, there is enough space to, you find enough space in the pelvis. This patient, you can see here, she had the multiple fibroid. The one fibroid was in the lateral wall, one was sitting in the top of the uterus. So with the help of monopolar and bipolar, the movements, it's like ballet dancing over there, because these are very effective cauteries, and you can use it very nicely. The trick is, what I do, I always suture the first defect first, because if you leave that first defect and then you go and enucleate another fibroid, then it keeps oozing, and there is a significant drop in hemoglobin in the post-op period. So suture your first defect first, and then you go to the another fibroid. You see this wristed needle holder. I think this is the biggest boon for a surgeon like us, because this has got the replica. They have made it the replica of human hand. At dexterity, it can move in the 7 direction. So even the movements are more than the human hand, and you can really use it very nicely. So the fibroids which are in the odd location, in the very low down in the pouch of Douglas, or the lateral wall fibroid, which are very difficult to reach with straight stick surgery, you can suture it very nicely. Another very important thing, all of us, whoever is doing surgery, they know the contralateral suturing is definitely better than ipsilateral suturing. So, and the short statured person like me, it's difficult to put your hand across to the patient and suture it. In Robo, there is nothing to keep your hand across, and you can take all advantage of contralateral suturing. So I'll show you, if you remember, I showed you I'm using the 4-arm of the Robo, and the 4th arm basically to use teniculum or the grasper. So this patient, the young patient, and she had very, can we forward this video a little? Yeah, little more. So this patient, she had very degenerated fibroid, and if you are doing the regular laparoscopy surgery, you have to, no, not the previous one, start from the middle. So this just, yeah, little more if you can forward. Yeah, so here you can see I'm using this tenaculum. So we all know these soft degenerated fibroid are very difficult to get hold with the myoma screw, and you are again assistant dependent. Here you use this tenaculum, which is very robust instrument, and with the help of this, the game, all of us we know, this is a traction and counter traction. So it's these myomectomy for these degenerated fibroid is very easy with the robo. So I'm talking about all good things, all pros for the robo, how good robo is. There are the cons as well. Number one, the con is we are not having any haptic feedback. So we do not know how much to tight, how the knot. Initially we break up many threads, and then it's difficult to understand which structure is hard or soft to touch with. But once the eyes are learning, once your brain is learning the art, you become the master of art. It's very easy to suture these. It's very easy to understand with the robo, and you can do very comfortable surgery. Another challenge in the robotic surgery is the cost. We know robotic surgery, the robo arm use, it cost around 1.6 lakhs to the patient, extra than the laparoscopy surgery. And this is really very challenging for the patients who have got no insurance, they have to pay in cash. But the good news is, again, many insurance companies, they are coming forward. Hardly, I think, 1 or 2 insurance companies, they are not paying for robo. All of the companies, they are ready to pay for the robo. So, and if you are able to convince your patient the minimum stay in hospital, minimum bleeding with the robo, and minimum pain. So minimum pain, you can argue with me, why minimum pain than laparoscopy surgery? The trick is in the robo surgery, the instruments are moving, the fulcrum of the movement is inside the abdomen. So the movement is not on the anterior abdominal wall, and which is again this is the reason patients are having minimum pain than laparoscopy surgery, and the patient can go back home. The higher cost can be well compensated with the minimum stay in the hospital, and patient can go back home on the second day of the surgery. So I just wanted to tell you about the uncontained morcellation. Uncontained morcellation, I think slide. Can we move forward? Not this one. So one should not be doing uncontained morcellation, because we know the risk of uncontained morcellation, besides spreading, upgrading the sarcoma, adenomyosis, but there is a risk of disseminated leiomyosis peritonealis, which we may think this is an imagination and very rarely happen, but I have seen the patients who got operated 3 years after the surgery. She came back to me, and when I put the scope, there was myomas loaded everywhere. This video is very interesting video. I just wanted to show all of you, and because when we do surgery, we are bothered about to do port closure only for the port which are more than 10 millimeter of size. But this patient who underwent surgery with me, and I was 100% sure that I did the port closure very nicely, and very 4th day of the surgery she started having nausea, vomiting, and pain in abdomen and distension. So we were wondering what went wrong, and when we did CT scan for this patient, and this was the picture. To our surprise, the bowel got herniated through the 6 millimeter of the port. So I just would like to give you take-home message, which is very important. When you do laparoscopy surgery or the robo surgery, when we do lot of manipulation through the 6 millimeter or 5 millimeter of the port, we widen up, unintentionally we widen up that port size. So the bowel can get herniated, and if whenever you finish the surgery, pay attention to that port also. If you see it got widened up, please do port closure for that 6 millimeter port as well. If this has been diagnosed within 48 hours of strangulation, luckily the bowel can regain the color and there is no necrosis, gangrene happen. But if it is more than 48 hours, then there is a possibility of gangrene to the bowel because of hampering the blood supply, and patient might end up in resection anastomosis. So please do pay attention to the 6 millimeter port as well. So I told you about the uncontained morcellation. Having said that, talking about the laparoscopy surgery, robotic surgery, if I say there is no role of open surgery, there is a role of open surgery. So if you feel like this case cannot be done laparoscopically, always plan your open surgery. And at the end of the day, your patient, not only you want to have your happy patient, but happy you to be yourself, and you want to have happy holidays, and you want to win accolades. Thank you so much for the patient's hearing. So if you have any question, I'll be happy to answer.
Thank you very much. The session is over now, so any questions for any of the speaker, for Dr. Reju, Dr. Girjaji and Dr. Ushaji?
Hi, Dr. Usha, very nice presentation. I just wanted to ask, not related to the surgery, there was a normal saline bottle which was hanging from the side of the console. What was that for?
Sorry?
There was a normal saline bottle which was hanging in the first clip that you have shown on your robotic console.
I'm not able to understand your question.
The normal saline bottle, a bottle of normal saline.
Normal saline bottle?
हाँ. Sure.
What are you saying?
मुझे लगा कि there is a bottle of normal saline which was hanging on the side of the robotic console where you are sitting at the handle. So what is that
In my
for?
first film?
In the first film, yes.
I'm not sure. Maybe the syntocinon drip or something?
But why along the robotic console? Why on the robotic console?
I have not seen.
Please check
you
it.
Want to see it again? I am not sure which bottle was hanging over there. Just show me once more.
Because this is a picture, yeah. You saw that, right? I thought it may be of some use. We can
you show me?
Sir, मुझे लगा maybe of some use we can also use it.
First, I think, first slide you
First slide, जिसमें
very first.
Just the photograph, just a pic.
This one?
That normal.
This bottle, oh, just to keep the phone. Okay. If you can. Oh my God. Oh God. This is. God. This is hilarious. Yeah, because there is no place to keep my phone. I kept my phone over there.
Is there any other question?
The good thing, you can take up the calls also in between. You stop the surgery and you can take up the calls. That is the beauty of
Absolutely, absolutely, ma'am. Is there any other question? So we'll continue with our felicitation. Our respected chairperson will felicitate our respected speakers. Dr. Reju, Dr. Girijawag and Dr. Usha M Kumar. मेरा फोन देखिए उनको बोल दें Thank you so much.